Ma'am, we are recording and we are live on YouTube now.
Yeah, Lata, please start.
Ma'am, first I'll give the introduction, then I'll hand over to.
Yeah, okay, Firoz.
So very good evening to all. This is Feroz Khan from Team Walter Bushnell. Welcome you all to this 11th live webinar organized by Indian Menopausal Society Education Committee on theme Reproductive Health and Midlife and Beyond. So without any further delay, I would hand over to Dr. Lata Iyer ma'am to take this scientific session ahead. Ma'am is one of the pioneers in gynae endoscopy in Central India, with more than 3 decades of experience in the field of endoscopy and fertility in India.
Slide share karo, madam ka.
Over to you, respected Dr. Lata Iyer ma'am, to take it ahead.
Hello, good evening, everyone. Yes, myself, Dr. Lata Iyer. With immense pleasure, I welcome you all to today's 11th webinar on reproductive health in midlife and beyond, presented by IMS Education Committee. I appreciate you all for taking out your precious time from your busy schedule to join today. I hope you will learn a lot. To begin with, I would like to request my best friend, Dr. Lakshmi Shrikande, a convener for today's webinar, to do welcoming address. She doesn't need any introduction. She is very known and multitask personality. Over to Dr. Lakshmi Shrikande.
Thank you, Lata. It's a pleasure to welcome you all for the 11th live webinar of IMS Education Committee. And this time we have taken the theme as reproductive health in midlife and beyond. And when we are talking of reproductive health, we have two issues. First, how to achieve pregnancy at this advanced age. And once they become pregnant, how to manage this pregnancy. So first two keynote address are on the first issue. And then we are having case-based panel discussion on how to manage the pregnancies in midlife and beyond. So it's a pleasure to welcome our National President, Dr. Ambuja, National Honorary Secretary General, Dr. Sudha Sharma, today's chief guest, Dr. Jaideep Tang, and the speakers, Dr. Gautam Khastagir, again Dr. Jaideep Tang, our panel expert, Dr. Jayam Kannan, chairpersons, Dr. Anju Soni, Dr. Jayashri Gachraj, Dr. Asha Jain, Dr. Anuradha Khanna, moderator Priyankur Roy, and all the panelists Ritu Hinduja, Niharika Malhotra, Manoj Chelani, Pratik Tambe, and Ekika Singh. And I also take this opportunity to welcome all the dear delegates who have logged in for this live webinar. So welcome all the esteemed faculties and delegates, and I hand over back to Dr. Lata for further proceedings.
Thank you, Dr. Lakshmi, for your opening remarks. It's my pleasure and privilege to welcome today's chief guest, Dr. Jaideep Tang sir, a orator par excellence.
Slide display karo na, Yogendra.
Pulse of wisdom. Is there slide? Can I have it?
Yes,
Dr. Jaideep Tang ka slide dikhao, and Dr. Anju Soni will introduce Dr. Jaideep Tang.
Yeah, over to Dr. Soni for the introduction of Dr. Jaideep Tang.
Good evening to all present here and who have joined the webinar. Though we are already, filled with webinars, but still, I feel it is one of the best medium we've got in this Corona times. At the offset, I would like to congratulate Dr. Ambuja for keeping each and everyone together with her sweet and humble words. That every member under her guidance has worked very hard and given so many amazing academic events as well as public awareness programs. Dr. Sudha has added her own flavor along with her to the IMS. Congratulations to you, Dr. Sudha. And now, Dr. Lakshmi, we already know her very, very well. She needs many, many more applause for conducting so many programs under her committee. And we all know that she's covered very, very important topics related to menopause. Congratulations, Dr. Lakshmi, for your every endeavor you have done in Indian Menopause Society. Now, it's my great honor to introduce Dr. Jaideep Tang. Well, what can I say about Dr. Jaideep Tang? He has been a strong leader. ensuring dynamic growth, high energy in every role he has taken. We are all very, very fortunate to have him today with us. He's such a dynamic and resourceful leader, Dr. Jaideep Tak. He's not only a great academician, a great orator, and an able administrator. He is the one who has worked very hard in bringing e-voting in Foxy. We all know that, which was a marathon job which he did in his tenure. And over my long association with him in last many years, I'm convinced that whichever endeavor he takes in life, he would bring a positive change in respect to the woman health and women of our country. We always say that his gray matter has knowledge of every subject, which answers for all queries, not only in us, but in patients and everyone. So, sir, welcome you, and my wishes for your every endeavor in future. I know you are standing for the post of President Foxy. We all know that your win is sure, but still you are doing so much of an effort. It is commendable, and best wishes for you, sir.
Thank you. Thank you very much, Anjuji. I hope I am audible.
Yes.
Yes, sir, you are audible.
So, thank you very much, Anjuji, for that, as always, very warm, kind, and very generous, if I may say so, introduction. If it appears that I'm moving a little abnormally on the screen, it's because I'm traveling in a car just now. So I just changed the background, because sometimes when I see people joining Zoom meetings from the car and I see the road in the background, I get motion sick. So thank you very much to the IMS for inviting me here. It's such a pleasure and a privilege to be chief guest here. I must thank and congratulate the president of IMS, Dr. Ambuja ma'am. She's really been working very hard. Her kind and gentle nature always shines through. Thank you also to the Secretary General, Dr. Sudha Sharma ma'am. Again, someone who's very dynamic, very focused. And madam, I'm looking forward to being in Jammu this Wednesday, where I hope I can meet you in person. Let me also acknowledge, thank you ma'am. Let me also acknowledge the wonderful efforts which the convener, my very dear friend, yes, in
Dr.
fact,
Jaideep, you are not
Dr. Lakshmi
audible.
Shinde is one of those
In between your voice broke.
Cutting.
I'm on the road.
Dr. Jaideep,
तेरी कार बाजू में 2 मिनट के लिए खड़ी कर दो ना. Just कार को halt करके you give your chief guest address.
Yeah.
That will be better.
Yeah, one.
हाँ, उसको ड्राइवर को बोलो थोड़ा सा हॉल्ट कर दे, कॉर्नर में लगा दे.
Okay, is that a little better?
Yes.
Much
Okay.
better.
Much better.
So thank you, Dr. Sudha Sharma ma'am. As I said, I'm looking forward to seeing you in Jammu on Wednesday. And let me thank, acknowledge, and appreciate the convener, Dr. Lakshmi Srikhande, who, as chairperson of IMS Education Committee, it's quite marvelous that Dr. Lakshmi Srikhande wears so many hats in so many organizations, and seems to not only do justice, but go above and beyond her call of duty in almost all the organizations and adds value to them. So thank you very much, Dr. Lakshmi, for all the wonderful work that you do. I'm delighted also to be speaking alongside someone I've known for a long time, Dr. Gautam Kastagir, and I look forward to hearing his presentation. And madam, you also put together some wonderful chairpersons, Dr. Anju Soni, Dr. Jayashree Gajraj, Dr. Asha Jain, Dr. Anuradha Khanna. Again, I've had the fortune of knowing them since so many years. I must especially appreciate the panel with the expert, Dr. Jayam Kanan ma'am. And, actually, to tell you the truth, the panel that you put together includes some of my most favorite people in Foxy. And it's always such a delight to see them, meet them, interact with them, and work with them. Dr. Jayam Kanan ma'am, I had the good fortune of meeting just recently. In fact, I remember when I was standing for the post of treasurer, Foxy, Madam was the first person to come and tell me, "You not asked me for your nomination, but I have already nominated you." And I've really had a wonderful relationship with Madam since then. And then, of course, there is the national coordinators, Priyankur, Niharika, Ritu. And I call them national coordinators in the true sense because they seem to be coordinating whatever is happening in our nation. And that day I was just telling Niharika and Priyankur that their CV folder must be so comprehensive that they must be having the CVs of everybody in our country. And the wonderful work that they do is always very much appreciated. And then, of course, there's Ekika. Ekika has recently got a publication with my very dear friend, Christoph. And congratulations on that, Ekika, and all the work that you're doing. And then there is Pratik. Pratik and me were residents together in Wadia Hospital. I was little senior, and we have done a lot of work together. And of course, then there's Manoj, someone I have been so many years. Thank you very much, Lakshmi ma'am, for having me here and indeed promoting me, if I may say so, as the chief guest. And I'm looking forward to joining back and giving my talk. Gautam, thank you very much for stepping in. I maybe leave for 5 minutes or so, and I'll join back. Thank you.
Jaideep, you have been promoted by our national president, Dr. Ambuja. She called me and she said, I am held up. Why don't you promote Dr. Jaideep as chief guest? So all credit goes to her. And welcome Jaideep as chief guest. And thank you so much for gracing our webinar as a chief guest. And now again, I hand over back to Lata for further proceedings.
Thank you very much, Dr. Jaideep sir. I now welcome our guest of honor, Dr. Sudha Sharma, a Secretary General. May I have a slide, please? Madam Sudha Sharma, she is a Secretary General IMS. She was an honorary professor IMA. She is Managing Committee member PCOS Society of India. Presently, she is Jammu OBGY Society.
Thank you, Dr. Lata.
President in 2000.
Thank you. Thank you. It's been, last 1 year we have been reading this.
Privilege, madam, let me read your CV.
No, it's fine.
He is Editor-in-Chief, Jammu JMH, Journal of Midlife Health in 2016 and 18. He is a member of Editorial Board, Journal of SAFOG, and Editor-in-General, JK Science Journal of Medical Education and Research. He is a member of National Advisory Board and Journal Committee in 2006 and 11. He is Associate Editor, International Journal of BGY, Gynae, India, 2007 to 12. She is a member, Editorial Board, Asian Journal, Organizing Secretary of IMESCON, faculty member of Consensus Document on Menopause and Osteoporosis, IMS. She had her in credit 70 publications, and she had edited 3 books and many chapters, 7 chapters in all whole. Thank you very much, madam. Welcome.
Thank you, Dr. Lata, for such kind words and kind introduction. So, a very good evening, dear friends and my IMS family. And today's chief guest, Dr. Jaideep, probably he has just left and probably is going to join very shortly. All the chairpersons, Dr. Anju, thank you so much for those kind words, and Dr. Jaideep also, expert speakers and young, vibrant panelists on this platform. So at the beginning, I really want to congratulate, Dr. Lakshmi Srikande, Chairperson Education Committee, for, successfully conducting the series of webinars, today being the 11th, every month without fail. And, you always invite excellent faculty across the country. And the topic chosen is so very important and interesting. It's making mothers out of grandmothers. Is that okay? So I just, want to discuss that this subject has gained so much of importance and so much of attention. We all know that, it's a challenge to deal with these patients, because we know there are so many complications and problems, dealing with these patients, whether they conceive, whether they do not conceive, and once they conceive, how to carry on with their pregnancy, because they are amenable to so many, comorbidities and problems. But I just want to share, few examples with you. You will agree with me that, during our grandmother's time, a woman of that age, they produced 10, 12 children. Most of them, they were healthy. So what is the reason behind? I will give you my example. My grandmother could not sit in my parents' marriage because she was in purpurium. So she has delivered my uncle, who is just a year and older than my, elder brother. She was one of the most beautiful and intelligent female on this earth, and she died at the age of 100 without any disease. Another example of my mother-in-law, again a very, very intelligent female. She produced 11 children. The last one at the age of 47 or 48, because she never believed in abortions. And all of them are super duper intelligent, doing so good in their profession. Nephews elder than, uncles. So was it ignorance, sheer ignorance, lack of awareness? Was it simplicity, less comorbidities? Was that lifestyle or environmental factors? We really need to look into it. And we are waiting to hear more and more from this expert faculty today. And all the very best for today's webinar. And thank you for making me a part of this event, Dr. Lakshmi. Thank you so much.
Thank you very much, Madam Sudha, for your pearl of wisdom. I would like to welcome Dr. Ambuja Charnoor for today's webinar. And with that, I would like to start a keynote.
You introduce Dr. Ambuja when she joins for her remarks, and thank you so much, Dr. Sudha, for joining and always appreciating the work done by IMS Education Committee. Thank you so much.
You are doing a marvelous work.
Thank you.
That we all know.
So, shall we start the first keynote?
Yeah. Of Dr. Gautam.
So I would like to welcome Dr. Gautam Kastagir, Founder, Medical Director, Birth, and Chairperson of Birth Inspire Foundation.
Dr. Asha.
For keynote on role of estrogen therapy. And to chair this session, I humbly request Dr. Asha Jain, Madam, Director of SMSA Hospital and Medical Director of NGO for Cancer Prevention and Relief Society, to introduce Dr. Kastagir. And I also welcome Dr. Anuradha Khanna to chair this session. She is the President, Varanasi Menopause Society.
Dr. Anuradha ka slide.
Yeah. And a Medical Director.
Yeah. Dr. Gautam ka slide project karo.
Dr. Gautam.
Yes. Dr. Asha, please.
Over to chairpersons. Thank you.
Thank you, Dr. Lata. And thank you, Dr. Lakshmi, for having me here. It is my privilege to introduce Dr. Gautam Kastagir. He is recipient of Wellbeing Research Grant in the UK, Reproductive Medicine Subspecialty Training at the Royal College of Obstetricians and Gynecologists. He has an RCOG accreditation in endoscopic surgery. He has published research papers in infertility, hormonal therapy, endoscopic surgery, published in international journals. He has provided hands-on training to over 250 doctors in infertility and gynec endoscopic surgery. Certain milestones are that he has been the organizing secretary of ISAR 2018 conference at Kolkata. He is the chairperson of ISAR Bengal State Chapter 2020 to 2022. He is then elected member, ISAR Executive Committee 2020 to 22. Organizing chairperson, ACE 2021 conference at Kolkata. Organizing chairperson, Yuva ISAR 2021 at Kolkata. Currently, he is fighting an election for librarian ISAR. So welcome, sir. and all the best. And we are waiting for your lecture. Welcome, Dr. Gautam Khastagi.
Thank you very much. Thank you very much, Dr. Asha, for that kind introduction. And before my lecture, I would, with your permission, with the respected chairperson's permission, I would just like to say a few words, which I say gratitude time. Basically, to start with, my heartfelt thanks to Dr. Lakshmi Shirikhande, a very good friend for last 20 years. And it is with her initiative, today's program, I'm here. And I know her for her enthusiasm for education, for clinical work and organization. And after seeing her and my other good friend, Dr. Jaideep Tank, who has been so supportive when I came back from UK to let me enter into the system, to understand the system in India. And I'm ever so grateful. And I'm sure he's going to win. And we will see him as a president. So being as a chief guest, many a time, some people ask me, why don't you do menopause? Because you have worked with Professor John Studd, one of the pioneers of menopause. So I say, yes, I do work with menopause patients because many of my patients are having ovum donation treatment. So it was very appropriate when Dr. Shirikhande asked me to talk in this program. I said, I'm going to share my experiences of estrogen, which is a hormone often not given that importance in infertility patients. We are just talking about progesterone, luteal phase support. My gratitude to Dr. Ambuja Madam, the respected president, and Dr. Sudha Sharma Madam, because you're doing a wonderful work in IMS. And I have been a member of IMS for a long time. Dr. Ratnabali Chakravarti in our state has made IMS in Kolkata really vibrant, and I was very active in the IMS conference in Kolkata. Now, finally, I'm ever so pleased to have Dr. Professor Jayam Kannan, whom I've considered as a walking encyclopedia, to be very honest, because you ask her anything and she has a solution, and she's so humble. You go and ask her anything, she will answer. And if you're in the incorrect path, she won't say that you're doing wrong. She will politely say, I would have done it in this way. So I'm really enriched. I'm really enriched. Truly, I'm really enriched. And I thank all of you, whether I become a librarian or not, but this journey has really helped me. My whole intention has always been to bring education to the forefront, to train our colleagues and juniors, and let's all work together. And I say this in every meeting. We Bengalis are very fond of Rabindranath Tagore, and he said his songs have to be sung in a particular way. So he has made the tune, not like modern songs, which you can sing in any way. So if you all sing in a particular way for menopausal problem, particular way for infertility and endoscopic surgery and pregnancy, then we will be the best country in the world in terms of giving service, because our population is our power. So the amount of work we do, sometimes we do not publish because of lack of time. So whatever strength we have with the population, we should utilize. Now, let me share the slides. I must say this, my wife would have said, once you start talking, you do not stop, let others talk as well. So let me just share my, just 1 minute. Right, can you see my slides?
Yes, yes.
Okay, thank you. But today I'm going to talk about ERT and ART. Interesting, isn't it? ERT and ART. Now, I've already mentioned why I would like to prefer on estrogen, because my teacher, John Studd, told me estrogen is actually the hero and progesterone is the villain. Why did he say that? He said all the good things in the brain, in the heart, in the uterus, everything is done by estrogen, and progesterone is of course necessary for protecting the uterus, but it is responsible for most of the symptoms, side effects like bloating, breast tenderness, irritability, PMS, everything is with progesterone. But he was referring to synthetic progesterone, and now we have both natural estrogen and progesterone. So they are very good friends. They are like twins. We need both estrogen and progesterone. Now, estrogen replacement therapy is of course essential. I was brought up by saying that every woman should have estrogen replacement therapy. But now with the Millennium Women's Study and Women's Health Initiative, that idea has changed. And you know everything about it, that we should not give estrogen to everyone. We should only give it to the symptomatic patients. But when we are doing infertility, when we are treating our patients with ART, we need estrogen in 3 different aspects. One is for the frozen embryo transfer, particularly those women who have irregular and anovulatory menstruation. In a regular menstrual cycle, you may do FET in a natural cycle, or you may give them ovulation induction with gonadotropin or letrozole, develop good endometrium and transfer it. But those who have irregular cycle, where you need to suppress the hypothalamic-pituitary ovarian axis with GnRH agonist, and then use estrogen and progesterone to develop good endometrium. In those women, we have been talking about, just our respected Secretary General Madam said, making mothers out of grandmother. Unfortunately, we can only do it up to the age of 50. I've treated many women between the age of 50 and 55. After lots of consultation and counseling, particularly after the death of their grown-up children, they were absolutely shocked and shattered, and many of them wanted to commit suicide. So one of my patients was at the age of 59, and she lost her daughter, 23-year-old daughter. Now, we ask ourselves, are we playing God? But the issue is, you develop an ethics committee, you ask non-medical person whether it is right or wrong, you talk with the family. If there is family support, we were really hesitant because she was 59 and husband was 65. So when this baby will be reaching adulthood, maybe both of them will be gone. So is it right? The child may come to me and say, who are you to bring to this world? But on the other hand, the desire is so much, but now we cannot do it with the new ART law. We can only treat women up to the age of 50. So these women would require ovum donation and embryo donation. We cannot say embryo donation now. So ovum donation and embryo and sperm donation. Now, the other big problem we have is the management of thin endometrium, which is very common in this part of the world because of genital tuberculosis. Now, it is true there has been a dramatic increase in the incidence of FET cycles because the results of our embryo freezing by vitrification is very good. We would like to eliminate the risk of OHSS. So we are using more GnRH agonist trigger and freezing all the embryos. Now, many a time what we see, there is better synchronization of endometrium and embryo if we do mild stimulation. But when you do hyperstimulation, there is advanced maturation of the endometrium. So the implantation is not so good. In these cases, what we do, we actually freeze the embryos and transfer them in a subsequent cycle. When we are practicing elective single embryo transfer, which I do because I've seen so many adverse effects of multiple pregnancy, particularly in high-risk women, particularly in elderly women, I've stopped transferring more than one embryo unless it's a repeated implantation failure or a very difficult case with a low prognosis. Those who are doing pre-implantation genetic diagnosis and screening, they need to actually freeze the embryos, wait for the result, and then transfer in the subsequent cycle. And finally, elevated progesterone in the late follicular phase, we all know, suggests that the endometrium may not be very good for implantation. And in those cases, we also do FET. Now, when we are talking about estrogen replacement, we have two common routes. One is oral and other one is transdermal. Now, if we look at the E1-E2 ratio, that is estradiol ratio, then we are not always aware the oral route gives an abnormal ratio between 3 to 6. And it also gives a much higher non-physiological level. much higher non-physiological precursor or metabolite. Whereas the transdermal route will give us a steady level of estrogen with the most physiological E1, E2 ratio, which is between 1 and 2. Now, it has been published that endometrium will react differently to the altered ratio of estrogen and to the different level of circulating estradiol level. So we need to keep two things in mind. What should be the ideal level of estradiol in the circulation, and what should be the ideal E1, E2 ratio? Now, the other thing we often ignore or forget, although we know it very well, there are some biological effect of estrogen to the other system. Oral estrogen will go through the liver and it will affect the hepatic proteins like renin substrate, sex hormone binding globulin, thyroid binding globulin, and cortisol binding globulin. By this hepatic effect, it will also alter the clotting factors and lipid profile. And thereby the adverse effects are hypertension, intravascular clotting, venous thromboembolism, and cholelithiasis. Interestingly, transdermal estrogen can avoid all such problems because it is avoiding fast pass effect on the liver. So it is getting absorbed directly into the circulation, and it is getting absorbed in estradiol form, which is the most important thing. Because the oral route is extensively metabolized in the liver and intestine, its efficacy is diminished by 30%. So we need to give more oral estrogen to get appropriate effect on the endometrium. And that is not the case with transdermal. And I've already said E1, E2 ratio is about 3 to 6 times higher. And estrone, we know very well, which is very high with oral estrogen, has a weak and lower binding affinity to both estrogen receptors, both a receptor alpha and beta. If you look at this chart, then the most ineffective is estriol, which we use transvaginally for local symptom relief. That is not effective in developing endometrium. So we should ideally use estradiol more rather than estrone because it has got less receptor binding capacity. Now, transdermal route of estrogen will deliver the exact amount. It is consistent, the levels are consistent. But what we have to remember, when you look at the endometrial thickness and the efficacy, both oral and transdermals work. But in some cases, which is a minority cases, with oral estrogen, you may not get good appropriate endometrium. And then you can add on transdermal, and that will prevent breakthrough bleeding. Now, excuse me, the other thing is the safety. Now, transdermal estrogen being expensive, many a time we cannot use it, but in those women who have other problems like liver disease, clotting problem, diabetes mellitus, hypertension, for them transdermal is more appropriate. And the question is how long you're going to use it. If you are basically using it just for 1 or 2 cycles, it really doesn't matter whether you use oral or transdermal. But in those patients who will be using it for a longer period, like someone with primary ovarian failure or premature ovarian failure, they'll be using estrogen for a long period. Maybe they will start it at the age of 30 and they will continue until the age of 50 because they just don't need it for ART. They need it for their general health, for their bone protection, for their psychological upliftment, for their regular menstruation. They need estrogen. So in those cases, transdermal will be much more appropriate. Now, this I wouldn't repeat because I've already mentioned the ratio is actually different with different route. If you look at the serum levels, on the top I have estradiol, and the bottom I have got estrone. In black, it is the normal physiological level. In the middle, the spotted one is actually the levels we have in the form of transdermal. And on the right-hand side, in the striped form, are the levels with the oral. So if you compare the top one, estrone one, you will see the oral estradiol level is much lower than the physiological. Transdermal is reaching almost midway or reaching the physiological level. On the bottom, if you come down, which is the estrone, again, transdermal and physiological are same, whereas oral levels are much higher. And this high level is also not desirable. If you look at the level over the period of next 24 hours after taking the medicine, obviously with the oral, there is a peak rise and there is fall. whereas with transdermal, the levels are consistent. But what is more important in this slide is if you look at the serum concentration, that is the Y arm, the XY axis, with the oral, you see the levels are in the range of 300, 400, 500. So the levels are very high. Whereas with the transdermal, the levels are less than 100. So we are achieving a consistent level at a much lower level, and we are getting equal efficacy on the endometrium. Now let's look at some of the evidence. This paper suggested that transdermal is much superior to oral when we are developing endometrial receptivity. Another paper suggested that no single regime is particularly better. As long as you can give 10 to 14 days of estrogen, be it oral, be it transdermal. In UK, we are using estrogen implant, which is not available here. Patches, we were using it, which is not popular in India because of sweating. But they say transdermal is superior to oral route for endometrial proliferation, particularly in those women who do not respond well to oral therapy. Now, there's little confusion about the estrogen gel. Sometimes patients think we are, or even some doctors think that we are using a large amount. We are prescribing it in grams. But what you have to understand, the gel is in gram, and amount of estradiol within that is actually in microgram. So if you give them 2.5 gram, either by scale or by 2 squeeze, you are only giving 1.5 milligram of estradiol. So the standard dose for ART is about 5 gram daily, 5 gram of gel daily, which contains only 3 milligram. So when you are giving orally, we usually use 3 tablets of estradiol valerate or hemihydrate. So orally, we are using 6 milligram, whereas transdermally, we are giving only 3 milligram. And I'll show you the evidence that even with the lower dose of estradiol, the response is actually much better with the transdermal route because it's much more effective. And the oral is actually destroyed in the liver and intestine. And this is a standard practice which majority of you are doing it. You are down-regulating with GnRH analog in those people who have the normal ovarian function. Start estradiol on day 2 or day 3. And as soon as you reach 7 millimeter or more, you start progesterone. And finally, you do embryo transfer. Now, endometrial response in IVF, they compared 3 groups of patients. One is the natural cycle, one is a down-regulated cycle, and one is the menopausal patients. Interestingly, what was found that the menopause, the natural cycle endometrium is very similar to menopausal patients. So menopausal patients having ERT will simulate the natural cycle more. Whereas in down-regulated cycle, they are not exactly similar to. So all these informations are important. So when a patient has lost her ovarian function, she should not think that everything is against. Some of the things are actually in her favor. Now, the next big issue is the thin endometrium. It's an ongoing challenge. And we all face this and pull our hair to see what we can do for this patient. We have done hysteroscopy, we have removed adhesions. Empirically, some of us have treated them for tuberculosis, but still it is not responding. Now, why thin endometrium is a problem? Because with these, what happens is spiral arterial contraction with the help of estrogen will actually reduce the estrogen tension in the functional endometrium layer. So when the endometrium is thin, the spiral arterial contraction is not so well. So there is increased oxygen tension, which we know reactive oxygen species can cause a problem and avoid implantation. If the endometrium improves in thickness from 6.7 to 8.5 millimeter in this study, the pregnancy rate jumped from 4% to nearly 40%. And what was shown that you have to use a very high dose of 16 millimeter daily from day 3 and not only 4 milligram from the day of HCG. So you need to use a high dose for a longer period. The question is it okay for the patient? Patients feel very sick with such a high dose orally. Now let's look at this data published in Human Reproduction, where they looked at frozen thaw embryo transfer success and they compared with endometrial thickness. We all know 7 millimeter is the ideal. Only 1 millimeter decline from the ideal will reduce the live birth and clinical pregnancy rate. So lower the endometrium, lesser the pregnancy rate. But interestingly, there was no difference in the pregnancy lot rates. So it's like on an all or none law. Once the pregnancy takes place, even if it's a thinner endometrium, the pregnancy actually continues. Now, other issue we have is the higher estrogen level actually lowers the pregnancy rate. 3 very interesting papers suggested that uterine gene expression for embryo implantation is best at a proper estradiol level, and it will become refractory if the estradiol level is very high. And also the window of implantation will remain open for a prolonged period when the estradiol level is lower, but it will rapidly close at a higher circulatory level. And next is the duration of estrogen. Now, sometimes we need to give it for a longer period till the endometrium is ready. And because we have downregulated the cycle, or because they do not have their own cycle, you can actually use estrogen. And this study surprisingly used it for some patients less than 21 days, which is obvious, 10, 12, 14 days. But in some patients, they had to use it from 22 to 28, 29 to 35, and even for 48 days. Of course, the numbers were very low. And what you see, the live birth rate is actually much lower, and early pregnancy loss is much higher. So higher the dose of estrogen, longer the duration of estrogen, you're not going to get your optimum results. So be aware of that. Now for APT, we have meta-analysis and randomized control trial, and they said there is no difference according to the type of estrogen. Let's be fair. Let's not just assume that transdermal is best and oral has to be put in the back cupboard. Nothing like that. We can still use both of them. Endometrial thickness and clinical outcome were similar, but it was shown that the miscarriage rate was lower with a tendency of higher live birth rate. So pregnancy rate same, miscarriage rate lower, so higher live birth rate. Now, my personal opinion is when you look at the studies, suppose they are analyzing, I'm just saying for saying, said 100 studies, then 90 they have used tablets and only 10 they have used gel, because gel hasn't been used that much throughout the world because it came later. So when you have more people using gel, perhaps this randomized control study and meta-analysis will favor more towards transdermal route. Now, another study published showed that estradiol level in the oral group was significantly higher, which I've already told you. Drugs consumption is significantly lower in the transdermal route. Cycle cancellation rates were lower. However, endometrial thickness, both groups reached optimum 1. Biochemical pregnancy, clinical pregnancy rates in this study was higher. Miscarriage rate was lower, but it wasn't statistically significant. Now, another interesting thing, this paper published from the armed forces hospitals in India, that you have a patient who has ovarian failure. She's not having periods. She has come to you. Are you going to treat them straight away? Or are you going to give them 3 to 6 months of cyclical estrogen progesterone to prime their uterus and then give them? It is definitely in women with premature ovarian failure or primary ovarian failure, estrogen progesterone therapy for 3 months should be done rather than treating them straight away, because it actually improves the pregnancy rate. How? By increasing the vascularization and subendometrial blood flow. And I've often seen the size of the uterus also increases. Uterus is such an organ that if you look after the uterus well, irrespective of the age, you can get good implantation. We know ovaries change with age. Uterus doesn't change that much as long as you look after the uterus well with estrogen and progesterone therapy. Coming to ovum donation and embryo donation, we prefer more physiological estradiol level. Most of the studies are saying that. And with the oral route, it is endometrium is out of date. You know, in good old days, we used to do Noah's criteria, looking at the endometrial dating. With the oral route, the dating is out by 1.6 days. Now, we obviously don't do, it's an invasive procedure to check the endometrium in the cycle we are treating, but in the treatment cycle, in the non-treatment cycle, people have done this research to look at the this dating. A meta-analysis has shown With the oral route, early pregnancy loss is much higher due to asynchrony between the embryo and endometrium. So whether you look at the FET cycle, whether you look at the ovum donation cycle, people are repeatedly saying that oral route, it may develop good endometrium, it may give pregnancy, but the miscarriage rate is, or early pregnancy loss is higher. And another study more or less saying the same thing, that in order to, before we can start the progesterone, oral route will have much higher estradiol level. It will take longer duration. The total dose of estrogen will be higher. Transdermal route can reduce the dose, reduce the duration, and thereby there's less chance of cycle cancellation, less cost of therapy. Therefore, it's emotionally much more acceptable. Now, this study said that transdermal estrogen allows the endometrial thickness of more than 7 millimeter as early as 10 days and with a much lower level of estradiol. So the level is 159, whereas with the oral route is 237. Higher endometrial thickness, 8 millimeter comparison to 7.6 millimeter with the oral route. Both of them are statistically significant. Progesterone could be started much earlier with the transdermal than the oral route, again statistically significant. But having said all these things, clinical pregnancy, miscarriage, and live birth rates were not different. So jury is still out. You do not have to use transdermal, but think about transdermal when you have patients who are having pregnancy and miscarriage, or recurrent pregnancy or recurrent implantation failure. Perhaps transdermal can do the magic. So ladies and gentlemen, I would like to summarize that in my personal experience and according to the papers I have presented to you, the transdermal route of estrogen will produce more stable state of estradiol. It is superior to the oral route for induction of endometrial proliferation and embryo receptivity. It is definitely a reasonable option for those women who fail to achieve adequate response with the oral route. And finally, and most importantly, it's a safer option, much safer option in women with high risk of venous thromboembolism and hyperlipidemia. So we will be doing more cases of frozen embryo transfer and definitely ovum donation and embryo donation. So estrogen gel is an effective method of hormone replacement for these women who would require estrogen. And the progesterone, you can use micronized progesterone, you can use dydrogesterone, whatever you want to do. It is great. I'll be ever so grateful if I could have the feedback from the learned audience and the respected seniors in this webinar. Thank you for your patient hearing. Thank you.
Thank you very much, Dr. Gautam, for your enlightening talk. Over to Chairperson, Dr. Anuradha, for concluding remarks, please. Dr. Anuradha?
Yeah, just a minute, please. Hello, good evening, everybody. It's always a pleasure to listen Dr. Gautam. I have listened his many talks, and they all were so knowledgeable, beautiful, and the way you deliver that really attracts everyone. And very rightly you said about the estradiol, that to the transdermal route, because that bypasses the liver. That is the most important thing, and of not affecting the coagulation factors. And it's very effective. Even in menopause therapy, I remember long back, around 15 years back, since it has arrived, many of our doctors were using it as a supportive therapy because liver is protected, coagulation factor is protected, no risk of thromboembolic phenomena. And very rightly you said that taking oral estradiol as a valerate or any other drugs, that may have some thrombotic effect, not that efficacious. As you mentioned, the endometrium will not be that thick, and it should be more than 7 millimeter. Rather, it is a thinner side maybe, and estradiol will work in a better way. So they all are very good things. And as you mentioned about the 3 courses of estrogen progesterone therapy, and rightly you said about the increase in uterine size and vascularity. And one thing is more, increase in receptors. which is very much important to have the effect of later on your stimulation and then the effect of progesterone later on we are supplementing, because giving estrogen progestins, they are vascularity and of course growth factors, of course receptors, they are very important. A very lucid and very nice talk by Dr. Gautam, and wish you all the best for the election of ISR. Thanks a lot, Dr. Lakshmi, for my involvement in this very prestigious webinar of IMS. And Dr. Sudha, nice to see you. And everyone, very nice to see you, Dr. Lata. And thanks to everyone. It's very informative talk.
Thank you, madam. Thank you for your kind words.
Thank you very much.
Dr. Anuradha, good to see
You can
you.
answer. There is one question. What is the dose of transdermal estradiol, and can they both be used together, both oral and transdermal?
If I'm using oral, I use 2 milligram 3 times daily. I go standard fixed dose from day 2 or day 3. If I'm using transdermal, I use 5 gram of gel, which contains 3 milligram of estradiol daily. Now, once, I give this both options to the patients, and I also tell them they go to the pharmacy and ask about the cost, because I always say this eastern part of India is not like west, north, or south. People's socioeconomic condition is really low. So many patients cannot afford. So I ask them, if you could afford, go and see, then you take transdermal gel. If you cannot afford, you can start oral. Now, if they're having FET cycle with the down regulation, they're just having it for 1 month. So how much damage is going to do to liver in 1 month? So let's be truthful. So I said, you can take either tablet or gel. Now, those who are having ovarian failure, they are taking estrogen for a long period of time, particularly those who are high risk. I usually suggest them transdermal. Many of them accept transdermal. A small proportion of patients will have allergic reaction, transdermal route, and they don't like it. But if I'm not getting good response with oral, then I combine the two. And if I'm not getting good response with transdermal, then I add the oral. But instead of adding it halfway through, I cancel that cycle and I start it later. So what I'm trying to say, I normally bring my patient on day 2 or day 3. I give them 10 days, ask them to come after 10 days. And if the lining is not good, I cancel that cycle and bring them next cycle where I'll be using higher dose. Oral dose, I don't increase more than 6 milligram unless I'm forced to, because they're not going to take. I've used 12 milligram up to 12 milligram. Sometimes they tolerate, sometimes they don't. With estrogen gel, I've used even up to 20 gram of gel, which means 5 gram in each thigh 2 times daily. So once after bath and once at bedtime. Now, at the end of the day, it is also important to look at the uterine endometrial volume. In many cases, we have found the endometrium is less than 7 millimeter, but the volume is 2 ml, 2 cc. So minimum criteria is 2 or 2.5. So I think there cannot be a uniform dose or uniform route for everyone. We have to individualize according to the patient's response, patient's socioeconomic status, and then take it from there.
Thank you. Thank you, Gautam.
I have to hear my friend Dr. Jaideep's comment. I'm sure he will mention in his talk, but it's good to see you, my dear friend.
Yeah. Lata?
Hello.
Yeah.
Jaideep sir is there?
Yeah, he's there.
Okay.
We will start with this session.
Continuing forward now, I welcome Dr. Jaideep Tang sir to deliver keynote on fertility in midlife and beyond.
Slide दिखाओ, योगेंद्र slide दिखाओ, Dr. Anju Soni का, Dr. Jayashree का. हाँ.
And to chair this keynote, I invite Dr. Anju Soni.
बहुत पीछे चला गया, और आगे जाओ, आगे जाओ, आगे जाओ. सबसे और आगे जाओ. हाँ, बस. Slide show कर दो. हाँ, बढ़िया. Yes, Lata.
Dr. Anju Soni, madam, she is she has a special interest in high-risk pregnancy, critical care and gynec, and minimal invasive surgery, urogynecology, menopause, and all other yoga vidya. She is a secretary-elect IMS 2022, and she is the chairperson of AIDS and HIV Committee, FOXY 2022. She is a president, Jaipur Menopause Society. She was a president in Jaipur Menopause Society in 2017 and 18. Committee chairperson, Public Awareness, IMS. Vice president of JOGS 2013 and 15. She's the secretary.
Thank you, Lata. Thank you. Let us say time for
Welcome,
academic.
madam.
Thank you.
Welcome, madam. And introduce from my side, Dr. Jayashree Gajraj. TV, please.
उनका slide है.
Dr. Jayashree Gajraj, madam, she is a senior consultant OBGY Chennai Apollo Specialty Hospital, Mangai Women's Health Exclusive, MGM Healthcare. She's a gold medal in clinical medicine. She's the past president of OGSSI, past chair of AICC, RCOGSJ, founder, secretary, and past president of Chennai Menopause Society, and president ATNRCOG, president SOBSI Tamil Nadu, best doctor award from Dr. MGR Medical University, and she has many publications and chapters in the textbooks. Welcome you, madam, and
thank you very much
for carrying out the keynote at this chairing this keynote address. Thank you very much.
Dr. Jaideep का slide दिखाओ. Yes, Anju, please proceed.
Yeah, for the people who have heard his Dr. Jaideep, who was the chief guest, must have heard his lecture, his thoughts of wisdom. But I would still like to introduce him again. He was Secretary General of FOXY from 18 to 21 and project lead for FOXY and Unicide. He was past president Mumbai Obstetrics Society and Deputy Secretary General FOG, and also immediate past chair International FIGO Committee of Safe Abortions. And besides that, he is a great academician, a great orator, and you'll find out in few minutes when he'll give his lecture on very, very important topic. We are going to hear from him. Welcome, Dr. Jaideep. Yogesh, stop share karo so that Dr. Jaideep can share his screen.
Thank you very much, Anjuji, again for that, as always, very kind, warm, and if I may say so, very generous introduction. I hope my slide is seen now and I'm audible.
Yes.
Okay. So let me again, in a new role, after being the chief guest, thank the IMS, the president, Dr. Ambuja, the secretary, Dr. Sudha, and the convener, Dr. Lakshmi Srikhande, for inviting me here. And also thank Dr. Anju Soni and Dr. Jayashree Gajraj. In fact, I met Dr. Jayashree Gajraj in person just day before yesterday when I was in Chennai. And I'm sure she will remember, she made this remark. It was a physical meeting and she said, the meeting was at 8 and when at 3:30, she said she panicked because she hadn't received the link, because she just assumed that in fact, so used to getting links for the virtual meetings. I am going to speak on fertility in midlife and beyond. But before I begin, let me request everyone who is here to please support me as I stand for the presidency of FOXY, a request I will be reiterating at the end of the presentation.
Okay, sir.
When you talk about fertility in the midlife and beyond, it stands to reason that ovarian reserve and all the discussion around ovarian reserve would be a prime concern, and that's what most of this presentation will actually focus on. But we'll also try to understand if fertility at 40 years of age is indeed a concern. And I'm just using the figure 40 rather arbitrarily, although 40 may be said to be for some people the early bloom of youth rather than midlife. And then we'll talk a little bit about treatment and treatment outcomes. So let's begin by addressing the question of whether fertility in the midlife is actually a concern. And I would have to say that this concern, besides being medical, is also a concern in terms of the narrative which patients are exposed to. If you look at some of the newspaper articles which talk about the fact that older mothers, late pregnancy, and what it means for what they call the business of healthcare. There is sometimes a view that perhaps we need to be a little more realistic about the chances of a spontaneous or even a conception with treatment, more particularly a conception with the woman's own gametes at that given age. This is particularly relevant now that the ART bill has got passed, and it is my belief that egg donation is not only going to become less accessible, but also more expensive. So a realistic picture of fertility in midlife and beyond is perhaps the most crucial thing to talk to patients in their midlife when we are counseling them for fertility potential as well as fertility treatment. Why is then fertility in the midlife a concern? Quite clearly, it is because of reproductive aging. It is an extraordinarily well-documented fact that fertility declines with age, and particularly when women cross somewhere around 35 years of age, it starts declining quite dramatically. Not only does the ovarian reserve decline, but even when patients respond, pregnancy rates are lower for women in the midlife. It is therefore very important that awareness be raised about fertility preservation, particularly for those women who would like to defer by reproductive choice their ability to have children later on in life. In fact, this quite interesting survey seems to suggest that the majority of women, an overwhelming 74% of women, would actually alter their reproductive life planning if they were identified as having low ovarian reserve on screening. It speaks to me of changing attitudes, and it also speaks to me about the fact that the technology surrounding fertility preservation, in this instance, oocyte cryopreservation, has now perhaps reached maturity, and we can, although not a panacea, fairly efficiently freeze oocytes and produce pregnancies from them. We'll then move on to ovarian reserve. And truly speaking, when you talk about ovarian reserve, it should remind you of this quotation that education is learning a lot about how little you know. I've divided the presentation on ovarian reserve into two parts. We'll first talk about defining, measuring, and preventing diminished reserve, and then we'll talk a little bit about what the treatment options are. When you think about defining and measuring ovarian reserve, a surprisingly contentious topic, the first thing we need to realize is that in literature, it seems to me that the term diminished ovarian reserve and poor ovarian response seem to be used interchangeably. If not in literature, then certainly sometimes in practice. And this is not only surprising, but is also to a certain extent limiting. If you look at what literature is available on diminished ovarian reserve and see the screenshot, and there are two screenshots here. One is the screenshot of a Medline search for diminished reserve, and there's another one which is a screenshot done for a Medline search for poor responders. You'll see that, in fact, the graph of the number of articles that have been published every year on diminished ovarian reserve is steadily increasing, whereas the graph on poor ovarian responders is actually been increasing for a while now, but also shows an equal number of articles. What this tells us is that we are now distinguishing between poor ovarian response and diminished ovarian reserve. And let's see why it's important. Before, however, we see why it's important, it's crucial to talk about poor ovarian response and then talk about diminished ovarian reserve, because as I said, a lot of times these are used interchangeably. So when you look at poor ovarian response, it is rather unfortunate that the definition of poor ovarian response has been very, very inconsistent. The Bologna criteria came out way back in 2011, which talked about some criteria for a poor ovarian response. But surprisingly, despite having consensus on the criteria for poor ovarian response, if you look at the literature between 2011 and 2018, that's the time the Bologna criteria were first published, and the subsequent 7 or 8 years, it was very surprising that only 51% of all the published trials actually used the Bologna criteria to define poor responder in their trials. Now, this is obviously a major problem, because if you have different definitions of a poor ovarian response, how can you compare one study to the other? It is therefore something of a plea that whenever we publish, we should use consistent definitions. But looking at the flip side of the coin, it is rather unfair to blame the authors who did not use the Bologna criteria, because there are problems with the Bologna criteria. For example, the definition of poor ovarian response is the same regardless of age. Ideally, this should be stratified as per age, and the degree of response or the number of oocytes should be stratified per age. That means the higher you go, the lower should be the criteria. There's an arbitrary selection of 40 years as the cutoff, and it really doesn't take into account factors like oocyte quality, etc. Having talked a little bit about poor ovarian response, we'll now move on to diminished ovarian reserve. And if you look at the data, it is really surprising to know that there are, in fact, or there were not, in fact, till 2015 at least, any studies that specifically deal with the issue of appropriate treatment for women with diminished ovarian reserve associated infertility. As I showed you in that graph of Medline, in the screenshot of the Medline search, there seems to be a confusion between poor ovarian response and diminished ovarian reserve. And this confusion probably occurs because of what I like to call the alphabet soup of diminished ovarian reserve. Out of 121 articles, the definition of DOR is so blurry that only 14 gave a definition for DOR. When a prominent association in infertility, that's the ASRM, arrived at a definition, it arrived at what best could be called a diplomatic definition. They just said women of reproductive age having menses, that's to rule out women with ovarian failure, whose response to ovarian stimulation or fecundity is reduced compared with women of comparable age. But what is reduced? How much is reduced? At what point do you say it is reduced is something that is unfortunately left out of the definition, which very nicely brings us to ovarian reserve tests. And I would have to say that the current ovarian reserve tests have the biggest limitation in the fact that they provide only an indirect measure of the cohort of recruitable antral follicles. Let me illustrate this and try to make it more clear. There is no test as of now which can accurately say that this is the number of recruitable antral follicles in this ovary, or it is at this level that you will get so many follicles when you perform an ovarian stimulation. Now, these are all the tests that we have used: FSH, AMH, AFC, inhibin, and clomiphene challenge test. However, in daily clinical practice, it's AFC and AMH that has the best sensitivity as well as specificity for predicting an ovarian response. What is very important while counseling patients, however, is that none of these tests is written in stone. Even the best marker at the best cutoff values is still associated with false positive rates of 10 to 20%. Obviously, if it comes to this, we should probably look at considering ovarian response during the first IVF cycle as a surrogate ovarian response test. When we look at setting cutoff values, particularly for counseling, it's really quite important to have extreme cutoff values. So for example, 0.5 to 1.1 nanogram per ml is the preferred cutoff value. However, you could, in some instances, have an even more extreme cutoff value that is lower if you're going to counsel patients about egg donation vis-a-vis trying with their own eggs. And this is because AMH and even AFC may be variable. Sometimes it does happen that there is a discordance in ovarian reserve tests. You have a normal AMH but a very low antral follicle count, or you seem to be having a normal antral follicle count and a very low AMH. What to do in those situations is something that is best left to clinical judgment. But if this is a patient who would be subjected to an IVF cycle, I would have to say that rather than choosing either an extreme low or high dose, this is a patient when there is discordance that you choose an intermediate dose. Of course, this could happen because there is something known as an upregulation of AMH secretion, which would typically happen in patients who have high ovarian response, but could sometimes happen in patients with poor response also. So to conclude that section on defining ovarian reserve testing, defining ovarian reserve and ovarian reserve testing, we don't have a uniform definition. AFC and AMH seem to be the best tests which are available, and always let's use extreme cutoff values when we are looking at these two things. As important as it is to make patients aware of the option of fertility preservation, it's as important to also prevent diminished ovarian reserve. And this can be done via fertility sparing surgery, particularly for endometriosis. As someone who does IVF, I really have forgotten now the number of patients who have come to me with repeated ovarian surgery for endometriomas and consequently with a depleted ovarian reserve. Therefore, I would like to give two important messages on this aspect. The first, and perhaps the most important thing, is all endometriomas do not need treatment. In fact, the large majority of endometriomas, particularly associated with infertility, will not need treatment. However, if you do decide to operate on a patient who has an endometrioma, then you have a decision to make. If the patient is concerned about fertility, you have to decide whether you want to do a cystectomy vis-a-vis fenestration and fulguration. There is absolutely no doubt that a cystectomy done will result in a much lower recurrence rate, no question about it. However, a cystectomy will also result in that patient being deprived of her oocytes. So when fertility is a concern, it's a good idea to select fulguration. So open the endometrioma, drain it, fulgurate the active deposits rather than doing a cystectomy, fully understanding that in this instance, your recurrence rate is going to be higher, but you're going to have a much better result in terms of ovarian reserve. Oocyte cryopreservation, as I've already said, is something which is gaining importance. It though needs a lot more awareness, particularly in patients. In the last portion of the presentation, I would like to speak a little bit about the treatment options which are available for diminished ovarian reserve. And one of the first things I'd like to say is that a patient with diminished ovarian reserve has to be differentiated from a patient who has already had a poor ovarian response, because overall, if a patient has received a diagnosis of diminished ovarian reserve, there's only a 30% chance that she would meet the Bologna criteria for poor response. Most of the other patients do all right with the response, which leads us to understand that diminished ovarian reserve and poor ovarian response are not the same. There is also the issue of whether diminished ovarian reserve translates always, or in which patients, into a poor quality of oocytes and therefore an epiphany. A diminished ovarian reserve frequently results in a poor response to ovarian stimulation. However, a poor responder is not always someone who has a diminished reserve. Patients who test normally sometimes can also have a poor ovarian response. So far, if you look at the principles of empiricity, which is first do no harm and give affordable treatment, it seems to me that although literature is awash with controversy about it, DHEA probably remains the best option that is available to us for managing patients with a diminished ovarian reserve. Various other drugs like this BSTCR, etc., have been tried. However, none of them have actually been shown to be of any benefit. The question, therefore, which faces us in our clinics is that when women who are more than 35 years come to us, should we tell them, go ahead and try on your own for some time? Or should we directly think of subjecting them to IVF ICSI when they have tests which indicate diminished ovarian reserve? In fact, if you look at the data, you can see that early initiation of infertility workup is associated with only a modest increase in the success. So even these women, if they have not had an adequate trying time, should be given an adequate trying time before subjecting them to treatment. A lot has been said about ovarian stimulation for patients with diminished ovarian reserve. Growth hormone has its own fans, has its own proponents. Personally, I have not really found the evidence to be robust enough for its use all the time. High doses of gonadotropin with or without clomiphene or letrozole have been proposed. Personally speaking, I would not really use clomiphene. I may consider the use of letrozole along with a high dose, and that remains my preferred protocol. I have never seen any difference between microdose, flare, or antagonist. I would actually think that the antagonist would give you a fairly good response. I'm really not a big fan of natural cycle IVF or minimal stimulation, particularly in this subgroup of patients. It's all right to consider it when the patient doesn't pay out of pocket. But in a country like ours, when patients pay out of pocket, I'm not really sure it's a good idea. And then now we have duostim, which has become quite popular. If you look at the principle of duostim, it is that you do a stimulation, do a pickup, and a couple of days later start stimulating again. The theory being that the wave of follicles will have increased in the luteal phase, and you'll be recruiting that and hopefully get a larger number of oocytes. It seems to me that whether you do a duostim immediately subsequently or you do two separate stimulations, ideally the number of oocytes should be the same. The advantage of duostim, which has been suggested, however, is that because you're stimulating in the same cycle in the luteal phase, the quality of oocytes may improve. However, there's really no evidence to support that. Corepolutrophin alpha, unfortunately, has not been shown to be of any special benefit. It is a very good thing, but it's not of special benefit in diminished ovarian reserve. What has been shown to have promise is luteal GnRH antagonist pre-treatment when you use it for patients with a diminished reserve. PRP is something that has been talked about a lot. However, I must say that if you look at the data, the number of Anjuji mute kar sakte?
Yeah.
Thank you. If you look at the data on PRP, you'll see that the mean number of oocytes that are increased may probably not be of any clinical consequence. I would have to say that PRP, therefore, should probably be regarded more as an experimental procedure rather than as something that we should offer routinely to our patients. Let me wrap up this presentation with the last couple of slides with this very nice remark in this paper which asks what is new in the management of poor ovarian response. And I really like this sentence which says, gonadotropins cannot compensate for the absence of follicles in the ovary. So till we find a much better way of generating a new cohort of follicles in the ovary, to summarize, the treatment options that we are left with for diminished ovarian reserve is the use of DHEA, a high dose of gonadotropins, perhaps with the addition of letrozole, the use of luteal phase GnRH antagonist. There are some who feel that doing an agonist protocol for this patient might be more beneficial than the antagonist protocol. I'm not really sure of that. However, one of the best treatments which is available for this is egg donation. And you cannot help but wonder what the impact of the new ART Act will be on third-party reproduction. We already know the impact on surrogacy. It is already being felt in the real world. However, these clauses that an oocyte donor can donate only once in her life, and this, I've been doing IVF for a very long time now, over 2 decades. And I must confess, and I had a meeting with some people the other day where I said that even after doing literally thousands of ovarian stimulations, I have yet to master the art of making sure that a donor gets only 7 follicles and I retrieve all 7 follicles and then I get all 7 mature. In fact, the government, when they drafted this clause, has been so optimistic that they have said, even after retrieving only 7, you will still have leftover embryos which you will be able to use. I cannot really understand the scientific basis of this. So let me end with this absolutely brilliant picture that I have found on the internet some time back. Now, this is a baby which is born to a lesbian couple in the UK. And as they say, it took 4 years, 7 attempts, 3 miscarriages, and 1,616 shots. I love this picture because it speaks to me of what our patients go through when they have infertility. After the baby was born, they wrapped the baby in the pride blanket, and they had saved all the syringes and needles, all those 1,616 syringes and needles. They surrounded the baby with those syringes and needles and then took this picture. And as you can see, it really is quite a moving picture. Thank you very much, IMS, for inviting me. Thank you for a patient hearing. And let me again request all of you to please support me as I stand for the presidency of FOXI. I have a website. It's called isupportjaideeptag.com. If you're watching this on a laptop, you can use your mobile to scan that QR code and it will take you to my website. Once you're there, you can register your support for me, and I'm so humbled and honored to share that literally thousands of Foxians have already registered their support for me. There is a video blog section where a lot of my presentations are there. And of course, you can elect to join the Telegram channel and follow whenever I give a presentation, I upload it on that. Thank you very much for having me here. It's a real pleasure and privilege. Thank you, Lakshmi ma'am, particularly as the convener of the program.
It's our pleasure, Jaideep, to have you. I mean, really, your clarity of thoughts and practical take-home messages always inspires us, and it is so useful for all our delegates who have logged in. So thank you. I invite Dr. Jayashree for her comments. Yes, Dr. Jayashree.
Thank you, Jaideep. As always, I think excellent diction, excellent delivery. That's with clarity built into it. And I think the important points that probably we need to summarize here are the subtle difference that you brought out between diminished ovarian reserve and the poor ovarian response, and the fact that they are two separate entities. So we, very well brought out by you. End of the day, it's the antral follicle count and the AMH values which actually are important, especially important because nowadays, once the AMH is done, the patients go on Google, try and get it, and they want to know the interpretation. So this value less than 1, I cannot have a baby, that panic situation comes in. So it's so important for us to explain that there is much more to it than just numbers. And the preventing diminishing ovarian reserve, excellent point brought out about endometriotic surgery, cyst surgery, the amount of damage that is done to every ovary every time a laparoscopic surgery is done for endometriosis. So that I love the word of caution that you have given to everybody. It's important and it's very well taken. The choice of stimulation agent and the lack of clarity, again, I think was well brought out by you, and the promise that is the duo stimulation may hold in the future. The fertility itself is something that is very, very, it's something that inspires a lot of effort, a lot of thought, because at the end of the day, you are producing a baby, and that's something the couple and the doctors, the entire team are so happy to see that baby. Even the baby, which you showed us just now, we all feel happy to look at it. So that's something great. I would like to wish you all the very best in the elections that are coming forth, and conclude by thanking Dr. Lakshmi and the entire team for having invited me and for making me a part of this wonderful program. Thank you.
Thank you very much, Dr. Jaideep sir, for your interesting talk. And thank you both the chairperson, Dr. Soni and Dr. Jayashree ma'am. And now moving forward, I would like to invite moderators, Dr. Lakshmi, a chairperson of IMS Education
Dr. Lata,
Committee.
can I say a few words?
Yes,
I just want to, congratulate Dr. Jaideep for, excellent talk, excellent presentation. As always, I must say, it's a pleasure to listen to your talk, Dr. Jaideep. I must confess that. And you made the things so clear messages you've given us. And I loved the picture which you shared at the end. We all agree that, infertile females, they go through a lot. And I wish you all the very best for your elections, not because just you are, Dr. Jaideep, because you truly deserve it. You worked so much for the society. You worked so much for the women welfare. So all the very best, and a warm welcome to you in Jammu.
Thank you very much, ma'am. Looking forward to it. Thank you so much.
Thank you, ma'am. So moving forward, let us invite moderator Dr. Lakshmi, a chairperson of IMS Education Committee, and Dr. Priyankur Roy is Zone Coordinator of Infertility and Endocrinological Committee, FOXY, to have case-based panel discussion on managing pregnancy in midlife and beyond. And I extend my warm welcome to expert Dr. Jayam Kannan, madam.
मैडम का स्लाइड दिखाओ भैया, मैडम का स्लाइड पढ़ो।
she is
बहुत अचीवमेंट्स है उनके।
हाँ बहुत सारे। She is a Foxy Adolescent Health Committee awardee 2013 and 15, Emirates Professor, Tamil Nadu MGR Medical University, Managing Trustee, Garbha Rakshahi Group of Institution. She is the Director of GFC Fertility Center, Trichy and Chennai. She is the Vice President, Foxy in 2018. She has a free legal aid center for women, Trichy, since 1992, and PMNCH WHO since 2008. She certificate course in reproductive medicine, Foxy, since 2012. She's the president. Her major achievements are President of India Medal for Outstanding Performance in MBBS, and winner of 13 medal and prizes in MBBS, and state first in MBBS and university first in MD, and best paper award 4 times. Best book in medicine award 2 times from Government of Tamil Nadu. Durusha SN Pandit, both Durusha and SN Pandit award, Foxy community work, best committee chairperson. Lifetime Achievement Award, IMA, Tamil Nadu MGR Medical University, Trichy Women Association, Tirumalapur Society of Siddhars, Academy of Clinical Embryologists, Best Society President Award in 2013, Foxy, and she has published books in medicine in regional languages, 5 and 1 English. She's a distinguished. She has received the Distinguished Service Medal 2018 award and the first Indian to receive this award. Welcome you, Madam Jayam Kannan, Madam. And I would like to invite all the panelists, Gynec Divas. Slide, please. Dr. Sambe, Chair AMOG's Endocrinology Committee 2022. Dr. Chelani, President, Raipur Menopause Society, both dashing doctors, and Gynec Divas, Dr. Neharika, a chairperson, Foxy Young Talent Promotion Committee 2022, Dr. Ritu Hinduja, Senior Consultant Reproductive Medicine, Nova IVF Mumbai, Dr. Ikika Singh, Managing Director and IVF Consultant, Sharda Narayan Hospital, Mau, Uttar Pradesh. Thanks for your presence and be ready for the discussion. Over to Lakshmi and Priyanku. Thank you.
Yeah, please stop your screen share. So I welcome Dr. Jayam and all the esteemed panelists. We are having a case-based discussion on how to manage pregnancy at midlife and beyond. Because Dr. Gautam and Jaideep have successfully overcome the challenge of achieving pregnancy for that particular woman at this advanced age. And now she has come back to us for pregnancy management. So friends, this is the quote: women are not dying because of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. Challenges are what makes life interesting, and overcoming them is what makes life meaningful. So now here we all are to overcome the challenge of giving her a healthy baby and having a healthy pregnancy for her. So plan of this panel discussion is a problem-based learning approach. We have got 45 minutes. We will share 3 to 4 cases. And we request all the panelists to be very crisp with practical take-home messages. So this is the first case, 43-year-old. She has come to clinic with amenorrhea of 3 months. She has been having cycles once every 2 to 3 months. For the last 2 years, she has no known health issues. She has 16-year-old daughter delivered by cesarean section for non-progress of labor. And she also had undergone an MTP 8 years ago. Both these procedures were uneventful. Now, what are the initial steps or the tests to be taken to assess the clinical scenario? Niharika, would you like to take this?
Good evening, ma'am. So as we know that this is a elderly age group female who's come to us, first of all, we would like to assess whether she is pregnant. So if she's pregnant or not.
Yes.
So if she is pregnant, then of course, elderly mother with a pregnancy with delayed cycles, ultrasound should be done exactly to know her gestational age, because of course our LMP will not tell us that. So she's 10 weeks gestation now. Because she is an elderly mother, a proper evaluation of her medical history here should be done with complete history, taking of her previous birth, whether she had any complications during that time, whether she has any chronic medical disorders like diabetes, hypertension. Also understand her genetic risk and age-related risk of pregnancy-induced hypertension, gestational diabetes, etc. should be done. And then give her a decision on what she wants to do.
So what will be your primary determinant in managing the situation? I mean, this given situation.
Ma'am, see, if she except age, if we don't have any other high risk factors, a good counseling with proper supplements, and if she's ready to continue the pregnancy, she can continue the pregnancy with proper follow-ups.
Yeah. Rightly said. Dr. Jayam, would you like to give take-home message to the audience before I move to the case, second case?
Yeah. This case is always a midlife crisis. Here, the counseling is the most important part, and depending on how the patient wants, because the years of gap is more than 15 years, depending on how she wants to continue, the positivity should be left over to the patient.
Because
ma'am, in this, I will be.
Yes,
ma'am, in this, I'll be like worried about both the mother as well as the baby. So my primary aim will be that she delivers a healthy baby. So initially, like as you said, she has come at the 10 week. So I would like that to do NT scan after 2 weeks or so, and then other, the double marker or other triple markers.
That
so
all
I want to
depends
make
on
sure
whether she wants the pregnancy to continue.
Yeah. So
Counseling
that
is the first thing that
exactly. Now she is healthy.
Take home message is midlife crisis, counseling properly, then proceed on the two directions which are expected in this patient.
Exactly. Now at present she is healthy, non-diabetic, non-hypertensive, but later on in the course of the pregnancy she may develop. So I'll be very careful about it. And so both I'll take care of the mother as well as the baby. So that will be my primary concern looking at her age.
Yeah. So I will not go into the theoretical aspect of the case scenario, but as you have rightly pointed out, Manoj, she is advanced midlife pregnancy. So yes, she needs the 11 to 13 weeks NT scan and double marker, then the anomaly scan and quadruple marker. I would like Dr. Jayam to comment on the role of fetal echo, because I would definitely like to have a fetal echo at 22 weeks of gestation. So what is your take home, Dr. Jayam, on fetal echo?
Madam Lakshmi, now it is up to 24th week. We are allowed a termination with the two doctors' opinion. But most of the cardiac problems get better evolved by 26 to 28 weeks. So Dr. Jaideep will very well accept with me that even if you make a fetal problem at 27 or 28 weeks, as earlier, the patient need not go to court and get a permission. Now, every district is supposed to form a MTP board, and the message has to go to the board within 24 hours. The board has to give the permission within 72 hours. And if she has to have the termination, it has to be done within 5 working days. That is the latest MTP Act. So, yes, earlier we used to be worried about doing the scan at 19th week and all those things. Now we need not do all those things. Now the rules are very clear that we can take it up with the MTP rules board, which is to be formed with an obstetrician, pediatrician, and administrative authority, one person.
Pratik, will you do double marker and then stepwise quadruple marker, or you will directly jump to NIPT? Pratik?
Thank you, ma'am, for inviting me. It's wonderful to share the platform with so many distinguished stalwarts. Greetings to everybody present. As far as the question of going in a stepwise and sequential fashion is concerned, we are presuming that this is a patient who is from a slightly better class of society, who understands what we are speaking, that they are receptive to modern trends, whatever are being discussed. But many of these patients come from a different generation. Many of them rely on us to make the choices for them. Even if we put the choices to them, we explain to them in detail with pictures, step by step, they may not understand everything that we are saying. So here the role of the physician as a counselor, as a father figure, as a mother figure is also important. I don't say that we treat them as if they cannot make their own choices, that we make the choices for them, but that we have to advise them appropriately. Also, we must remember that patients have a lot of choices these days. You may say something to her, she may get confused, or her relatives may confuse her when she's at home and she may go somewhere else. So whatever small window of opportunity you have, you advise what is the best possible at that juncture. If you don't do that and if you don't document that, patient is lost to follow up and later on she turns out to have a complication. In these particular litigious times, it's quite possible that we may be blamed that we did not give the appropriate advice at that point of time. So if she comes in the window period for a double marker, do the double marker. She comes in the window period for a fetal 2D echo, as you said, advise it, document it on paper, whether or not she chooses to undergo it, whether or not she chooses to follow your advice, to spend the money, that is left to their discretion. Be very careful in dealing with these kind of patients, because in this group of patients, you can have sudden maternal deaths, you can have unexplained deaths, you can have high uncontrolled diabetes, which will present itself.
To the maternal aspect.
Yes,
Jay, your take on this fetal aspect, whether we should do double marker, quadruple marker, or NIPT. Just a quick take-home message for our audience. Because now everywhere NIPT is being promoted like anything. Jayam?
Yes, NIPT is almost coming to be the order of the day. And since it has made it everything non-invasive, and it gives about 99+% success, even it may become a medical legal problem if at above 40 years in Indian scenario, we have not given the option to the patient to do NIPT. If the patient refuses, in which case we have to take a proper undertaking with a witness so that we are not pulled up to the court of law, and they hand over the baby to us for taking care of it further.
Yeah, Pratik has highlighted that aspect that we have to take everything, we have to document. Now, Erica, I am coming to the maternal aspect. She is in her 40s. So how will you assess this mother for her well-being during this pregnancy?
Ma'am, for her case, as the moment she comes...
Your volume is low, Erica.
Can you hear me now, ma'am?
Yeah. Yes. Oh.
Ma'am, since she is an elderly patient who is pregnant, so the moment she comes to our clinic, regarding whatever the period of gestation is, she has to be thoroughly screened for any medical problem if she has. Now she has come here in her first trimester of pregnancy. So during that trimester of pregnancy, regarding her age, I would like to additionally do her HbA1c and even her lipid profile also is required to know what is the status. Besides that, as the pregnancy advances, the risk of GDM, the risk of hypertension is more in them. So accordingly, at times, I might have to do glucose challenge test and for her a tight control on her blood pressure and the monitoring and a frequent ANC visit. That is how I'm going to monitor this patient.
Yeah. Pratik, you were talking about this maternal risk. So I would like to invite you on this aspect of her management. Pratik?
So at every single stage of pregnancy, be it first trimester, second trimester, labor, active phase, postpartum, post-delivery after going home, the incidence of complications is manifold once a woman has crossed 40-45 years of age. especially in the perimenopausal period where there are a lot of changes in the physiology. You're going to have a compromised cardiovascular system. You're going to have a compromised response of the kidneys also. There can be maternal overload because of congestive cardiac failure. We often fail to even auscultate these patients. We just take it for granted that since all obstetric patients are otherwise, in inverted commas, healthy, normal women, we presume that these women also will have a normal physiology. But that's something which we can't take for granted. Always do a physician's reference. In major metros where there is access to a cardiologist, try and have at least one color Doppler or a simple 2D echo that is done for the mother. X-ray test is something which we normally don't advise in pregnancy, but at least a simple cardiologist referral with an ECG, with a 2D echo or a color Doppler is something which should be part and parcel of the initial workup of this patient. If at all that person wants to institute any treatment, that has to be followed to the letter. Proper follow-up is, of course, essential.
Yes,
The issues about sugar have
Yes.
already been mentioned by Dr. Ekika. We also fail to take into account that many of these women can be obese and overweight. They may have multiple nutritional deficiencies, calcium, micronutrients, all these which are usually found in good, adequate levels in a younger woman may be deficient in elderly women. They must be compensated.
Yes, Pratik, you have highlighted the point that since she is in midlife, ECG and her echo should be done. I think Jayam, you agree with me that whether she undergoes normal delivery or cesarean section or whatever, but we should not forget the cardiac assessment of the mother, apart from cardiac assessment of the fetus. Niharika, I am coming back to you. She wants termination of pregnancy and she is 10 weeks at this age. So how you will proceed for termination of pregnancy?
First of all, I would like to ask her why she actually wants termination of pregnancy at 10 weeks. Because if it is only the reason for age, then we as obstetricians should counsel her regarding it, because she has no other high risk factors and she only has one child, so she can continue this pregnancy. If they really insist on termination of pregnancy at 10 weeks, because her previous cesarean was a very long time back, we can offer her medical termination of pregnancy, can try and then go ahead with the consent.
Yeah, Niharika, because now we all are going through that respectful abortion care training. So we can't preach, we can only counsel, and if she wants, we have to offer her abortion care. But she has done anomaly scan and she's 22 weeks with lethal anomaly. Now the job is easier, I think, with the amended MTP Act.
Yes.
At 22 weeks with the two doctors thing, you can go ahead and offer her termination of pregnancy. So now let us come. Jayam, would you like to wind up and give take home on your this first case?
Yes, the first case is an unexpected midlife crisis. A patient is taken by surprise that she is pregnant. The doctor knows that she has seen this in about 25% of the women above the age of 40, those who have not been sterilized. Though the doctor is little cool and talks to her well, but the patient is little agitated. She is not able to decide what she has to do, especially if the first child is going to be the sex which she did not want. And she always eager to find out what sex this child could be. So that becomes a big turmoil, and she has to decide whether she has to keep it up or terminate. And however, if supposing she decides to continue, she has to have the very rigid high risk checkup. And should she find out any problem in the anomalous scan, she has to immediately take up the problem with proper high-risk delivery unit. However, the mother has to be always checked for her cardiac and GDM and blood pressure care.
Yes, thank you. Pratik, can you see Priyankur? Is Priyankur there because he is held up in the OT?
Ma'am, he's an OT, ma'am. I called it.
Okay, so here I am proceeding with the second case. This one is 41-year-old. She is 16 weeks pregnant and this is an IVF pregnancy. She has history of preterm birth at 24 weeks, rupture of membranes and easy delivery, and that was also IVF pregnancy. 10 years back, 10 years of infertility, she had conceived with IVF. There is no history of diabetes, hypertension in previous and in present pregnancy also. All the routine tests which we do are normal. Anti-scan at 12 to 13 weeks is showing you cervical length 3 centimeter. So what next? Neharika, how will you take her concern for miscarriage, because she is really anxious and apprehensive?
Ma'am, in this case, we can see that she has now 3 high-risk factors with us, like age, then a IVF pregnancy, and then obviously a previous history of premature rupture of membranes. But because of her medical disorders are actually normal in the history and her NT scan is normal, her cervical length at 3 centimeters is considered normal. But as obstetrician, we would like to do serial cervical length measurements in this case to follow her up regularly. Secondly, we have to understand that she can go again into preterm delivery. So prevention of infections and anemia has to be on top of our list. Progesterone supplementation here has to be added, a probiotic, which is very important. And I would also like to add an omega-3 right now and follow her up regularly as within 3 to 4 weeks every time.
Yeah.
Ma'am, she had a previous abortion and spontaneous abortion 24 weeks.
Yes.
So, and cervical length is okay, but still I think it's at 16 weeks. So I think it is the time we can give her encirclage. I mean, there's no harm in
Coming to that only. Can you justify, Manoj, why you will prefer a cerclage even though the cervical length is 3 centimeter? I know she has got history of PPROM and this is IVF pregnancy.
Yeah, ma'am, that's what I'm saying. It's a precious pregnancy, age oil, and previous history is there. Previous history is important. Though I do agree that cervical length is okay, just a borderline. But still, I would like to take precaution, and I know it's a little controversial, little tricky.
It is controversial.
Yeah, I mean, there are 2 thoughts about it, but still, I think
I am taking opinion of all the panelists. Ritu, will you go for cerclage or not for this lady?
Ma'am, can I answer?
Yes, Ritu.
Yeah.
Please.
Ma'am, if asked for a personal opinion for her case, she is an IVF pregnancy. First pregnancy was also IVF, which was delivered preterm. So it's not only a precious pregnancy in a mental perspective, even economically also it is like a burden on them. So giving a cerclage for her is, I don't feel it's any harm. If it is done properly in very aseptic way, it is definitely is going to be a big add-on for her. So looking at her history and looking at her age and looking at everything, I think it should be done for this patient, though her cervical length is 3 centimeters.
Pratik, your take on this issue? Pratik?
If you look at the guidelines, they say either progesterone or cerclage, the most recent updated guideline. That is what the theory says. But sometimes what we do in clinical practice and what we do in theory are 2 opposite things. I would probably give the choice to the patient, and she would ask me, what would you do if I was your relative? 90% of patients ask me that, even today, even in an educated background. So I say that sometimes it's better to be safe than sorry. And I would concur with what Dr. Manoj says, that sometimes we need to be seen as doing something, even though we know that it may not give much clinical benefit. Because tomorrow you don't want the patient or her relatives to come back and say, "Aapne kyun nahi kiya?" Because I'm pretty sure that somebody else would say, "Yes, ye doctor ne karna chahiye tha, lekin kiya nahi because he was following the textbook and the guide." Sadly, that is the situation of practice in India today.
Yeah, Neharika, your take on this, and then Jayam will finally give her take on the role of cerclage in this kind of situations. Yeah, Neharika.
के साथ आप मुझे debate करा रहे हो.
Youngistan है ना, करो.
I actually, frankly speaking, I don't really believe in doing cerclages unless very indicated. I would call her again at 16 weeks, then maybe decide, not as early as 12 weeks. I'll call her again and then decide.
Because cerclage has got its own set of problems. So, yes. Jayam, now as an expert, what take-home message you would like to give to audience on the role of cervical?
40 years plus, second IVF, I would like everybody to look at her with the ESHRE guidelines, recently 2020 guidelines on recurrent pregnancy loss. Forget that she had one abortion because it is an abortion, it is a fetal loss after IVF. So consider her like a recurrent pregnancy loss. That means you start with a tender loving care, aspirin, progesterone, consider about encerclage appropriately as Neharika has put in, and low molecular weight heparin also, which has been put up in 2020 ESHRE guidelines. That also, whatever you can, as per guidelines, should be given to her. Forget that she had one loss. You think that she had two losses because one IVF pregnancy is equal to 3 IUI pregnancies. So take it that way. If she has lost one baby, that means she would have lost 3 babies also.
Also
so
would like
yeah.
Ma'am, also want to add the cervical encirclage only from an experienced hand.
Yeah. She has to have a cervical encerclage appropriately placed after having ruled out well about length and breadth, front and back, about the chances of infection. 10 years ago, what she had lost, even 10 years ago, IVF patients were very rigorously monitored. I know very well from 2000. The first 10 years, 12 years, it's okay. From 20K, it has been very well monitored, and 10 years ago, I don't think anybody would have missed cervical length, and I'm very sure she would have gone in for some sort of a infection. And this time we have to keep a very positive look on infections, add probiotics, and also add vitamin, calcium and vitamin D also. Because calcium has been shown to be very much helpful in these patients also.
Yeah, so then you have covered all the points of the progesterone therapy, cerclage, antibiotics, and what is the role of steroid? Is there any role?
Yes, nowadays steroid is being advised at
24 labor. Yeah.
In 24 weeks itself, even Government of India guidelines says. So this patient, if we are able to get her on to 23 weeks plus, by the beginning of the 24th week, she should have steroids. Even by basic Government of India guidelines, we have to take it. By 26 weeks, she comes for delivery. By a rare chance, she should have had a steroid by 24 weeks.
If you are giving it 24 weeks, then would you like to repeat it, and when?
Then the question of repetition comes only by 32 to 34 weeks. It doesn't come before that, because we should think that the patient may have a chance of delivery 4 to 6 weeks after the last steroid, in which case it should have been done by 32. Because whatever we have given at 24 weeks, we'll be able to take care of the baby up to 30, 31 weeks.
Yeah. Ritu, you are here with me? Ritu?
Whoever is there, please put on your video so that...
Ritu, you can elaborate on the prophylactic progesterone, the role of progesterone in preterm labor, what dose, what route you will prefer? Neharika, if she is not there, you can tell us about the progesterone.
Ma'am, progesterone, as said, has been one of the most studied drug, and it is actually the best for preventing preterm deliveries. We understand that progesterone actually maintains the uterine quiescence. It blocks those inflammatory responses which happen, which can cause labor. So therefore, I think progesterone is one of the most important things to be given in anywhere you predict that preterm delivery can happen. Routes, there are different routes which progesterone can be given. It can be given in injectable, vaginal, oral. It depends on what you actually prefer and have studied in your clinic. My preferred routes are either a vaginal route or an injectable route. I prefer these two, any of which my patients are comfortable with.
Yeah, Manoj, what is the role of bed rest? Because she's so anxious. So how you will counsel her about the bed rest? The role of bed rest?
Ma'am, not much. Like, we obviously will be monitoring her regularly, and she will be like on drugs. So it's absolute bed rest. I don't think it should be indicated looking at her like just because she had a past abortion history.
Yes, Pratik, role of prophylactic tocolytics in this case?
I think we've now come to an era where we don't believe in prophylactic prophylactics except progesterone. The old days when we used to give isoxaprine for 34 weeks, 35 weeks, that's a bygone era. We don't do that anymore.
Good. So now all those isofast and your duodelan and all these, you mean to say that there is no role of these tocolytics in this case? Jaya, your take?
Prophylactic tocolytics is indicated only if you have not given steroids, and we want to tide over the crisis of that 48 to 96 hours to get the steroid into the body of the baby. After 24 weeks, probably we can think of prophylactic tocolytics at the time of problem. Otherwise, there is no role for starting all the isoxaprines right up to by 5th week, 6th week of pregnancy.
Yeah. So now Manoj can continue here. Now at 31 weeks of pregnancy, she has come with draining of liquor and spotting. You have done ultrasound, the AFI 7.1, but you can't see any active leaking when you have done the perspectivum examination. You have kept her under observation. You have given her prophylactic antibiotics. What next?
Yes, ma'am. So, prophylactic antibiotic has been given. And then as Karan ma'am has already said that steroids can be repeated once we have given in 24 weeks. Now again she has come, so this is the time to give antibiotic, and Maxelsa can also be given to prevent her from going into labor.
Yeah, rescue short steroid Jayam has already covered. Jayam, what is the role of magnesium sulfate? Should it be given?
Yes, at 31 weeks, especially for neuroprotection, we need to give Maxelf, and that is very much required for these patients, depending on her further progress of liver. And this dose of Maxelf is like what we give for eclampsia. This.
Is there any role of amnio infusion?
Not in current medical practice, no.
Good. So it should not be done. So 12 hours later, she has progressed into labor. She is into active labor. Cervical dilatation is less than 3 centimeter. Effacement is less than 50%. Baby is alive, normal, kicking. You have found that membranes are intact. So now how you will proceed? Membranes are intact and yeah. Now, Jayam, you were talking about the role of tocolytics when there is a problem. So now here is a problem. So would you like to give tocolytics?
If she has not been given steroid, I would like to put her on tocolytics. If she had been already done a stitch, now it is going in for dilatation. That means the stitch has to be removed. Yes. If Ekika said that she will do a stitch, if she has done a stitch, that stitch has to be removed. And the tocolytis can be only for the period up to the steroid cover-up. Because if she has already gone in for 3 centimeters, that she is already into the latent phase of the first stage of labor. So we have to accept it. And because it is 31 weeks now, many centers are ready to take care of this baby. If it is not so, kindly do not keep it in a single doctor unit. Please send the patient to a unit where there is high risk delivery and NICU care.
Yeah, in utero, very good point you have told, Jayam, that we have to shift in utero rather than first delivering, doing section at your place, then telling the relatives that we don't have a good NICU, transfer the baby. So that is not a good practice. Transfer her wherever there is a good NICU. Correct. So Pratik, would you like to give some practical tips in the management of preterm labor? During labor, what precautions should be taken for the mother and baby?
Especially in patients where there has been leaking silently for quite some time, they're quite prone to dry labor. And when this happens, it often happens that there are disturbances in the CTG. So continuous fetal monitoring would be ideal. 1:1 nursing and doctor care should be maintained if possible, though that's not something which is always practical. We need to ensure that we don't miss any variable decelerations or late decelerations, which are a common occurrence in these patients, especially with cord compression. In these patients, you might see precipitate labor or you might see obstructed labor also, depending on the status of the cervix. If previously she has suffered a PPROM and she has had a preterm delivery at 24 weeks, it's quite possible that the cervix might be torn. There can be cervical tears in this particular delivery as well. It could also be that the cervix is fibrosed, which means that the fluid will all leak out, and that will lead to dry labor, and that will lead to obstructed labor as well. Be liberal as far as cesarean section is concerned, because salvageability in modern NICUs is excellent. Don't always aim for vaginal delivery at any cost, because in trying to do a vaginal delivery, you can lead to greater fetal compromise, and be guided by the CTG tracings. Be liberal for cesarean, early intervention, ensure your neonatologist is present, and as Jam Madam said, ideally the neonatologist has to be present at the time of delivery, and quick transfer into the appropriate care settings is ideal.
Yes. Jayam, you would like to give take home on this second case before we quickly cover the third case? Yeah.
The second case is a case who is very anxious to have the baby because she has already lost a baby, and she has to have all the tender loving care with all the points of rulement, whichever has been discussed, right from first trimester NIPT to second trimester serial scans to prevention of preeclampsia, GDM, and steroids cover up appropriately with a follow-up after 24 weeks every week if possible, or else at least every 15 days. After 30 weeks, weekly follow-up is required. And if she goes in for labor before 34 weeks, a delivery at the high-risk delivery unit with the proper NICU care. And in all these cases, the presentation of the baby becomes very, very important. If she is already a breech, we are not going to think of a vaginal delivery. Even in the breech, preterm delivery at 40 years has to be taken. And if we had put a stitch, that stitch has to be removed. Pediatrician, obstetrician, and proper physician care after the age of 40 is very, very important in these patients, because she has spent so much of her life anxiously to get this baby.
Has Priyankur managed to log in? Pratik, can you see Priyankur? Okay, so no, he is held up in OT. So this is the last case which we will cover in this panel discussion.
Priyankur is not here, but Ritu has logged in. So maybe we can have Ritu during the panel.
Ritu कुछ बोल ही नहीं रही है. Ritu,
yes, ma'am, I'm here. I am here, ma'am.
Yeah. So this question is for you. This case is for you. 45-year-old woman. She has conceived with IVF with egg donor cycle. Now she is 15 weeks pregnant. Before ART, she had no medical issues and health screening was normal. Her first trimester fetal screening is normal. So how would you screen her for gestational diabetes? Ritu? Quickly, you can tell us about the DIPSI criteria and all. Will you approach her differently because she is over 40 years of age?
So, ma'am, basically, yes, because she's increased maternal age, we would kind of put her in a high risk category and screen her for gestational diabetes. Of course, there are different criteria, and we would kind of, use those to screen her. I think Jayam madam can help me answer this question because I don't do a lot of ops and I don't want to give the wrong message.
Government of India has already endorsed the DIPSI criteria. Jayam, her
in this patient, I would beg to differ with the DIPSI criteria because she is 40 years plus. I would rather do her a fasting and 2 hours postprandial only and see that her fasting blood sugar is not above 85 milligrams. If it is going to be above 85, I would think that she is going to be a bullet, which will come at any time with gestational diabetes.
Yeah. So Jayam, her fasting sugar is 91, and after 75 gram glucose load, her sugar is 154.
Yes, that is what as I predicted. she is a patient with gestational diabetes mellitus because she has crossed the postprandial criteria of 140, and I would like to see that she is appropriately handled with insulin in the first trimester, and probably insulin continued. Depending upon her need in the third trimester, it has to be taken up.
Pratik, at 19 weeks, she has come with a normal anomaly scan report, but her BP is 136/88. What next?
So before I answer this, I just wanted to add something to the entire discussion. Remember, we are dealing with a woman in midlife. We also have a woman who may have unexplained comorbidities which we may have failed to uncover. Remember that these women, when they are diagnosed as having an abnormal or deranged HbA1c or a fasting or a postprandial, these women are classically not the ones who will respond to medical nutrition therapy. By all means, offer it to them for a couple of weeks, repeat the sugars after that. But these women are going to require good, strong doses of OHAs or ideally insulin for strict glycemic control for the best neonatal outcomes and to ensure that we do not have maternal complications in addition to perinatal and neonatal complications. I hope that message is going to the audience.
Well said,
That's
Pratik.
something which we as ART clinicians have experienced time and again when we do only ART and we send the woman to somebody who takes care of obstetrics. They fail to take all these other factors into consideration. Coming to the issue of now her landing up in addition with borderline hypertension. This woman is a ticking time bomb. She is going to need institutional care. In the good old days, we used to admit these women till term, monitor them daily, do their US-UK, do their urine albumin, ensure that they don't have flying knee jerks. Personally, we used to monitor these ladies because at any point of time, they could explode, they could convulse at home if they were left unmonitored. And if they had uncontrolled GDM, in addition, they are also unfortunately the women who would be prone for sudden IOFDs. And that's a big tragedy. If you have a woman at this age with multiple comorbidities landing up with an IUFD, because then you are left with the situation where you might have to do a cesarean section for a dead baby. I don't think any obstetrician in modern practice would relish that prospect.
Exactly. Yes. Now, Manoj, we are coming to the fetal well-being aspect. So this slide is for you. How will you assess the fetal growth? Would more ultrasound scans be justified for her, and when should they be done? And how will you counsel her, tell her about the daily fetal movement counting? Will it be useful for her?
Yes, definitely, ma'am. The daily fetal movement counting should be done by her. And we will do the Doppler studies for the baby and we'll see how these things are. And accordingly, we will call her. And I'm sure we would have also done her fetal echo also. And that is also important at this age, like maternal age and all with other conditions. So fetal movement, obviously, that is very important.
Yeah, because we have to do ultrasound plus Doppler plus biophysical profile as per our clinical judgment and as per her presenting complaints or signs and symptoms at that particular moment. So now, Erika, I am coming to the timing of delivery. Can you take this question? At what gestational age would you like to deliver a woman who is 40 years of age, or particularly this case scenario which we have discussed? When you would like to deliver
Ma'am, in this case, I mean, I would like to add one thing before going on this. As far as fetal well-being is concerned for Doppler, like initially we saw that she could be a patient landing up into GDM. She could be a patient who can land up into gestational hypertension. Age is a high risk factor for her. At 24 weeks, a Doppler should be done. Because at that time, we can come to know whether there are increased bilateral uterine resistance or there is any other resistance going. If she has an increased bilateral uterine resistance at 24 weeks, then she has to be monitored more vigorously for her fetal growth. And then, yes, if it is normal later on, then at 32 weeks, a Doppler has to be repeated. Now, if this patient comes to me and she has everything as a normal parameter, I will, right from the 32 weeks, I might tell her to come every 15 days, and from 36 weeks onwards, I will monitor, I'll tell her to come weekly. And then wait for her delivery till 38 weeks, she might go into spontaneous labor. But if she has any of this problem, maybe a GDM or hypertension, then what is the state during the progress of her gestation in the 3rd trimester? Maybe my decision will be decided on that. If she is a high risk pregnancy, her blood pressure is 170, 110, which is not controlled or poorly controlled, the moment she reaches maturity, I could go for advise her for termination of a pregnancy that time. So normal parameters, I might be more vigilant.
Mode of delivery for this woman, our case 3.
Again, the textbook answer would be to do a Bishop score, look at the inducibility of the cervix. In practice, 99% of us would deliver her by a cesarean. I like to be practical.
Yes.
I like to be practical in life. I don't give theory answers because everybody can read theory.
Manoj, you can tell us about the postpartum problems, because in midlife after the delivery, they have the postpartum issues. So what are they and how you will tackle them? Whether she's a high risk, but in midlife after the delivery of the baby, there are many issues. So
ma'am. So after the delivery of the baby, we'll do the immediately after the delivery of the baby, we'll do the monitoring of the fetal this thing also, glucose levels also, and then what you call it, we'll monitor the mother also. How her glucose levels are there, if she's on oral hypoglycemic age, advisor to take taking.
Is she more prone to go for puerperial psychosis, and what about the chances of lactation failure? Would you like to comment on these two issues postpartum? Yeah, I know we will manage her diabetes, her hypertension, but in midlife she is about the puerperial psychosis and lactation failure. I think we have lost Manoj, network issues. Neharika, would you like to comment on these two issues?
Ma'am, most of the elderly women have a tendency of lactation failure. To actually control this problem, we should actually keep counseling them throughout their pregnancy, because they have to be mentally ready in lactating and also understand the importance of breastfeeding. So I usually start my counseling as soon as they get pregnant, that yes, you have to breastfeed, you have to exercise during your pregnancy, a good protein diet and everything, so that they are actually followed up and they're ready at the time of delivery.
Very true. Manoj is not. Pratik, you want to add something?
Yeah, postpartum blues, depression, psychosis, all of them are going to be much more common, but these are easily tackled. The more life-threatening issues are something which present in the postnatal wards, where patients are just dumped and we don't monitor them. These include sagittal sinus thrombosis, postpartum eclampsia, hypertrophic obstructive cardiomyopathy, pulmonary embolism. All of these are very common in patients of this age group, especially when they have just delivered, everything is fine, we feel baby is going home, patient is going home, and suddenly on day 3, day 4, you will land up with a major complication like this, which could lead to a maternal mortality as well. And therefore, good follow-up, regular monitoring, physician reference, ensure that her sugars are tested, and all the appropriate precautions are taken.
Yes, Jayam, your concluding remarks on case 3.
Yeah, 45-year-old, gestational hypertension, GDM patient coming for a proper checkup, should have a very, very apt follow-up weekly after 30 weeks. And between 24 and 30 weeks, depending upon her problem, she should have weekly or once in 15 days. I will prefer a delivery at 37 weeks itself, as everybody has been thinking, and it is in a proper setup again, in a theater with all facilities for management of postpartum hemorrhage, pulmonary embolism, ventilator facility, and with other cardiac managements also. And the pediatrician should be just by the side of the obstetrician to receive the baby and transfer it in utero to in incubator. That is how the baby has to be managed, and the baby has to be looked for the hypoglycemic, hyperglycemic, and calcemic symptoms, and that has to be followed. Because it is not only the mother, because she at the age of 45 when she comes, she doesn't have the care of her mother-in-laws or sister-in-laws or even her mother and father, because they all would have become very elders, and they may just come casually as a visitor only. Only her husband may stand by the side, or any of her friends will stand by the side. It is only the obstetric unit or the IVF unit which has to be very close to her and hug on to her and take care of it. Postpartum blues is possible in the absence of all these things because she is worried. When I am 60, my child is going to be 15 years. What will I do if I get any problems? My husband is already 65 years. If he gets a heart attack, how will I look after this child? These are the things at this age gives rise to postpartum blues, and this has to be prevented by our hugging on to the patient, both by Pratik Tambe's IVF team and by other obstetricians who are going to be there looking after her in her delivery.
Thank you, Isayam, and all the panelists for giving clear-cut messages on how to manage these 3 different case scenarios in midlife. So thank you all, and I hand over back to Lata for her vote of thanks. Lata, are you here? Yeah.
Thank you, Lakshmi.
Thank you for including us. Wonderful panel, good choice of cases. Most of the complications that we can expect were all tackled and discussed, and fantastic panelists.
Thank you so much.
Just wait for 2 minutes. She proposes vote of thanks, and then we will wind up. Yeah.
Thank you.
Yeah.
On behalf of IMS, I thank you today's chief guest and speaker, Dr. Jaideep sir, guest of honor, Dr. Sudha Sharma madam, Dr. Gautam sir for his valuable talk, all the chairpersons for today's 2 keynotes, Dr. Jain, Dr. Soni, Dr. Anuradha, and all the chairperson, and all the panelists, Dr. Neharika, Dr. Ritu, Dr. Ekika, Dr. Tambe, and Dr. Chelani sir, along with our moderator, Dr. Lakshmi, for their participation in case-based discussion. I humbly thank Jayam madam for enthusiastic advices in each case. And last but not the least, our webinar sponsor, Walter Bushnell, today. And a big thank you to all the audience for joining in this academic feast. Thank you once again, especially Dr. Lakshmi, for giving this chance. Thank you all.
And
all the best, Dr. Gautam and Dr. Jaideep, for your election.
And thank you, Lata, for the smooth conduct of the whole webinar. Thank you so much.
Thank you.
Yes. Thank you. Yeah, you can stop. Chalo.
Thank
Bye.
you. Bye-bye.
Thank you.
Bye.
All the best to Dr. Ekika and Dr. Niharika also for their.
And you also.
And to Manoj also. All the contesting candidates, all the very best.
Thank you, ma'am.
Lakshmi ma'am, good to see you after hibernation. We were missing you.
I am here only.
Ma'am, hibernate.
All the time busy with
she disappeared for a while.
Acha.
Chalo, bye.
Bye. Bye, Manoj.
Thank you.
Bye. See you all. Bye. Bye, Anju. Thank you for staying till last. Bye. Bye.
Thank you, ma'am. Should I end the meeting?
Yeah.